Okay, so orbital tumors, I'm sure all of us have diagnosed, all of us have treated, some kind of one or the other kind of orbital tumor at some point in our practice. So I will just focus in this talk on. It's not coming. Okay. So we all know orbital tumors mostly presents with a proptosis, and there is if you get an imaging done, there is a mass in the orbit on an imaging. That's how typically we think of orbital tumors. So since this topic is on masquerades, I will not be showing the typical orbital tumors, but some of the cases where, it could be like, it might not look like a typical tumor presenting with a proptosis or a mass, but the presentation of an orbital malignancy is somewhat different. So this is how we typically see the spectrum of the orbital tumors: a proptosis, orbital mass, which could be there in any location of the orbit. Sometimes it can be extensive, causing a fungating mass. Sometimes it can cause displacement of the orbit, can involve the eyelid and the surrounding structures, and it can go on and on. So if the presentation is something like this, we all know the diagnosis. We are dealing with a malignancy. And if on imaging we see that there is destruction of the bone, there is erosion, it is going out of the orbit, then we can be a little bit more sure that we might be dealing with a malignancy. Then we do biopsy of these patients, we get the diagnosis, and we treat them accordingly. So with this, let's move on to some cases. So this is a gentleman. As we can see, he's an elderly gentleman. He was being seen in the OPD. His complaints were mainly visual. He had come for his cataract surgery. His cataract surgery was done. Following that, his complaint was he used to get this persistent irritation. Then he was diagnosed as having conjunctivochalasis because the clinician found that there was a lot of redundant pink appearing conjunctiva, and they did an excision of the excised conjunctiva. His symptoms did not get better. He still has the same complaint. And then over a period of time, he started to develop this drooping of the eyelid. He had a ptosis. So it was thought that it's a senile ptosis, aponeurotic ptosis, which was hampering in vision, and that's the reason this patient was referred to us for correction of the ptosis. So in the clinic, when you saw this patient, this is what we find. Is this a normal senile aponeurotic ptosis? Do you all agree? So what else is there which tells us that it's not a simple ptosis? There is some fullness of the eyelid, absolutely. The superior sulcus seems to be full. If we compare it to the other eye, in a normal ptosis patient, it should not be so, right? So there is something else going on other than a simple ptosis. So if we look at the fornix, if we just try to pull the eyelid and look at the fornix, this is what we see. Now we know what we are dealing with. Dr. Vikas has already shown us the same picture. What is this then? Lymphoma. So this is again a salmon pink appearance, a mass which is there in the fornix. It's almost coming out of the fornix towards the bulbar conjunctiva, and it is pink colored. So this is the typical appearance of an orbital lymphoma, and when it comes down into the conjunctiva, we can see the color like that, and it can, since it's an infiltrative lesion, it can infiltrate the levator muscle, the superior rectus muscle, and it can cause this ptosis and sometimes restriction of the movement also, though not very common. So what is typical of in the imaging, as in our keynotes picture, the radiologist has shown some picture that it is a very well-defined mass, homogeneous, and it seems to be like molding around the orbit. That is how it is typically described. It does not invade the surrounding structure. It does not cause destruction of the surrounding structures or invade the bone. It just finds its way along the whatever way path it is there. It usually goes along the globe or maybe in between the muscles. So that is how it typically appears on the imaging. So when we do the biopsy from this mass, it turned out to be diffuse large B-cell lymphoma, which is a lymphoma with a relatively worse prognosis and not a very common subtype which we see in the orbit. Ultimately, this patient turned out to have multiple abdominal lymph nodes. His bone marrow was positive, and then he had to undergo the protocol of treatment with systemic chemotherapy and then radiation to the orbit. So acquired ptosis with eyelid fullness, whenever there is an acquired ptosis, especially if it's asymmetrical in an elderly patient group, we should look for other signs which could tell us that it's not normal ptosis, like fullness of the eyelid or any subtle proptosis or any restriction on the movement, which will tell us that we might be dealing with some infiltrative pathology. Okay. Similar patient, she also came with this, kind of bags of the eyelid. In the right eye, it's in the lower lid. In the left eye, it's in the upper lid, right? So how many of you again think it is a normal eyelid bag or it is something else? Okay, I'll show you the CT scan also. I'll show you the conjunctival appearance also. So again, we know we are dealing with a lymphoma here, but here it is a bilateral involvement. So lymphoma can be bilateral, especially if there is a systemic association. And if you see the imaging here, we can see the typical molding of the, do you have a pointer here? We can see the lesion, which seems to be fairly well defined. It seems to be going nicely between the orbital walls and the globe and not really invading the structures. So if you do the biopsy, we'll get the diagnosis and we just need to treat the patient accordingly. So how many of you have treated or diagnosed a patient of pseudotumor at some point in your practice and treated the patient with steroid? I'm sure all of us have done it, right? So these are the patients, these are the type of patients, specifically lymphoma, which are most of the time misdiagnosed as pseudotumor, and then they're given steroid. Lymphomas are known to be very responsive to steroid. So once you give them steroid, it is going to disappear for some time, but ultimately it's going to come back after some time. And in fact, if you are suspecting a lymphoma, we are diagnosing the patient, or we are doing the biopsy when the patient is on steroid, then we actually might miss the diagnosis. So if you suspect a lymphoma in a patient who might have been otherwise diagnosed as pseudotumor elsewhere, then do stop the patient steroid for some time, maybe 4 to 6 weeks if possible, and then go ahead with your biopsy. Otherwise, you might miss the diagnosis. And if pseudotumor should remain a diagnosis of exclusion, if you find the features to be atypical, not fitting into a typical inflammatory pathology, do get a biopsy done, confirm your diagnosis, exclude any other specific pathology, and then start the patient on steroid. So we all know what it is now. It's the salmon pink appearance, which is a feature of an ocular adnexal lymphoma. And these are the type of patients which can be misdiagnosed as a conjunctivocalysis, because sometimes they come out of the fornix like this, can cause an ectropion. And if you don't know the clinical appearance, if you don't know the color, then we might miss these patients. So as the principle of any orbital lesion, this is what we usually follow when you have to diagnose a patient of orbital lesion or treat them. Either we do an incision biopsy or excision, or we debulk at times, we do FNSE sometimes, or sometimes we don't do anything in the orbit. These are usually the things which we do. For a lymphoma, it's the incision biopsy that we do, because we really don't have to chase after this lesion, don't do very extensive surgery. They respond very well to radiation or to chemotherapy. All we have to do is to diagnose the lesion by biopsy, and then go ahead with the further treatment along with an oncologist. Moving on to the next case. So this is a gentleman, comes with a bilateral prominence of the eye, proptosis, asymmetrical, right eye more than the left, and he has a lot of retraction of the eyelid, upper lid retraction, lower lid retraction. So what do you think? Do you think it's an proptosis? It's a thyroid eye disease, proptosis? Thyroid eye disease. Doctor, I can see Dr. Gangadhar sitting here. Thyroid eye disease. Okay, so what was little unusual here, like it can very well, yeah. So this is a thyroid eye disease proptosis, like it's an active disease, bilateral, asymmetrical, and it seems to be in the active phase. Somewhat similar patient. Do you also think this is also thyroid eye disease proptosis? Why? Okay, this is much more asymmetrical, seems to be unilateral, right? And what else does he have? He does have some congestion of the conjunctiva. He does have some chemosis, which are all features of active thyroid eye disease. What else does he have? He seems to have some congestion of the blood vessels at the lateral rectus insertion, which again could be a feature of thyroid eye disease. But since the proptosis was so asymmetrical, the eyelid sign, especially the other eye, was not very marked, we thought of getting an imaging done. Right? Yeah, corkscrew blood vessels. Yeah, Ferrous can pick it up, okay, even without the imaging. Okay. Superior sclerosis is not there in the other eye, yeah, but thyroid eye disease we know can be asymmetrical, right? Okay, so we got an imaging done for this patient. He seems to have thickening of the lateral rectus muscle, which can explain the pathology which is more prominent on the lateral part of the orbit. So do you still think it's a thyroid eye disease? Why? He has a thickening of the lateral rectus muscle. Thyroid can cause thickening of any of the extraocular muscles. Yeah, so it's a reverse. It got reversed. The imaging got reversed, sorry. Okay. So is this, otherwise, if you just look at the muscle thickening, is this thickening typical of what we see in thyroid? Classically, what is described is sparing of the tendon, which does not seem to be there in this patient. It seems to be diffuse thickening, looks somewhat more like a myositis thickening, right? But since he was not very symptomatic, did not have too much of pain, not much of tenderness or anything, and he already had received steroid, has not responded, so we decided again to go ahead with the biopsy. This is what we see on biopsy, a thickened lateral rectus muscle, which appeared somewhat pinkish, which might not be very apparent in the photographs, but again, it turned out to be a lymphoma, the NHL lymphoma. So extraocular muscle involvement can be there in lymphoma, and they can be isolated involvement also of the extraocular muscle, which can sometimes mimic a thyroid eye disease. Another patient, again with a proptosis. He has a proptosis, he had eyelid retraction, very asymmetrical. Does it fit into thyroid? Not really, because yes, he has this, lot of swelling here in the lower lid area. The other eye seems to be absolutely fine, there is no congestion. So this again needs an imaging. We got an imaging done, and this is what we see. He has thickening of the lateral rectus, he has thickening of the medial rectus. He has proptosis, of course. Does it fit into thyroid? Though there's no definite orbital mass, it's mainly the extraocular muscles. All the muscles were thickened, in fact. I have the coronals also. So does it fit into thyroid? The inferior rectus, medial rectus, lateral rectus, superior rectus, all are thickened. But what was unusual in this imaging was, within the thickened extraocular muscle, we can see the lucent areas, hypodense areas, which should not be there in a thyroid thickening, right? So again, so that's the reason we thought we need to do a biopsy. We are missing something here, and when we do the incision biopsy from one of the extraocular muscles, this is what it turned out to be. So he has, we can see these signet ring cells, which are atypical. So what is the diagnosis then? Liposarcoma. It's a very unusual orbital, a very rare orbital tumor, but sometimes it can present with again an extraocular muscle thickening. And what could be a clue to the diagnosis would be the presence of this lucent area, which could be because of the presence of that, what do we call that, mucoid sort of material within the lesions. When we reviewed the literature about liposarcoma, we actually found in most of the patients with what has been reported, it says that there are lucent areas within the CT scan, within the lesion on imaging. So this could be one of the clues to your diagnosis that we might be dealing with a liposarcoma, though it's a very rare tumor. Yes, myxoid liposarcoma. No. Okay, so ultimately this patient had to undergo an exenteration because there is no specific treatment for liposarcoma. So moving on, a patient where we see a demonstrable increase in the size of the lesion. This was a CT scan done 3-4 months back, and this is when he had presented to us. So within a span of couple of months, we see that the lesion has grown considerably. Though it looks like a very well-defined lesion, there is no bone destruction, but with this kind of growth, we need to suspect a malignancy. So growth is one of the features of malignancy, and if we have to take care of this lesion, how are you going to do it? You are going to do an incision biopsy, you are going to do an excision biopsy for this tumor. What should be the plan? Incision biopsy, or it looks like a fairly well-defined tumor, why not excise it, right? So we found intraoperatively also, this is the clinical photograph, it seemed like a well-defined tumor, so we could excise it completely. So we did an incision biopsy, very well-defined, lobulated surface, yellowish, whitish appearing lesions. So what do you think it could be? Benign or malignant? So a well-defined tumor like this is usually supposed to be a benign tumor. Most of the time the pleomorphic adenomas look like that. So we also thought so, and this is the gross appearance of the lesion, a white appearing lesion with some areas of hemorrhage within some variegated areas, which could be again like a pleomorphic adenoma. The site was unusual, it was in the middle orbit, which does not fit into pleomorphic, but was surprised this is what it turned out to be. A very, very highly malignant appearing tumor, so this turned out to be a pleomorphic rhabdomyosarcoma, which is again a very rare orbital tumor presented like a well-defined orbital mass. But the documented growth on CT was a clue that we are dealing with something which could be highly malignant. Dacroadenitis, again, we all treat them. It could be unilateral, like an acute dacroadenitis presenting like a ptosis, S-shaped deformity of the eyelid, and sometimes it can be bilateral, chronic, where we just see swelling of the lacrimal gland. So acute dacroadenitis, if there is no other cause, we treat them with, depending on the extent of the involvement, we treat them either with non-steroidal anti-inflammatory or with steroid. And bilateral, if it's like a repeated episode, if they're not responding to a steroid, then we might have to do a biopsy. So a lady comes with 3 months history of swelling of the eyelid, lot of erythema. It started off like a small S-shaped deformity. That's what she said. In fact, this was somewhat like this, and this is what the imaging is. So what is your differential diagnosis? How do you approach this patient? Do you think it's a dacroadenitis, acute dacroadenitis? The history is about 3 to 4 months. It started off something like this, went on to progress to, when we saw her, this was something like this. No history. No, she's not giving any history of. So initially we thought, like, with the lacrimal gland swelling on CT scan with a subacute or acute picture like this, we thought we might be dealing with an acroadenitis sort of thing. We gave her treatment, she did not respond. Like, it used to get a little better with the steroid, but used to come back. So we stopped the steroid, waited, and then we went ahead with a biopsy. Has been investigated. No, has been investigated. In fact, she came with all the investigations, with the whole body kind of, So nothing was there, so we did a biopsy. This is not the photograph of the same patient, but this is what it was. It turned out to be lymphoma again, and it was a malt lymphoma. So what was unusual in this patient was the presentation like an acute, almost like a pre-septal cellulitis. And it is known that, like, lymphoma can involve the lacrimal gland, and also T-cell lymphomas are known to present like a cellulitis, like a more aggressive disease. But this lady actually had a B-cell lymphoma, which presented like a picture of a pre-septal cellulitis. Another patient with a bilateral swelling here, with a bilateral lacrimal gland enlargement on imaging, and when we did the biopsy, it turned out to be a plasmacytoma. Ultimately, on systemic workup, he did have multiple myeloma. So sometimes they can present like, lacrimal gland swelling also. And the dictum is, if a acroadenitis, if it is recurrent, it is not responding to your treatment, go ahead with a biopsy, confirm the diagnosis, and then treat them, do the specific treatment. This is a young girl, 15-year-old girl. She comes with this proptosis, with a displacement of the eyeball, with some fullness here. So we expect something here. There is a little inframedial displacement of the globe, and this is the imaging. A lacrimal gland tumor, adenoid cystic carcinoma, because we know that in this age group we can have adenoid cystic carcinoma, but it seemed fairly well defined, which again could be a feature of adenoid cystic carcinoma. There is no bone destruction. So again, we went ahead with the differential diagnosis. It's a lacrimal gland tumor, either an adenoid cystic or probably a pleomorphic, and based on the intraoperative appearance, we decided to go ahead either with an incision or an excision biopsy. What was unusual here, which told us that it was adenoid cystic, was that it was probably that, the lacrimal gland swelling, as a dictum, is that if it crosses the midline, if it's going to the middle orbit, possibility of it becoming a malignant is more than an pleomorphic. So on intraop, what we found was a bluish, greenish appearing tumor, which is typical of a granulocytic sarcoma, which is a localized form of acute leukemia. So ultimately, this girl had, on bone marrow evaluation, her bone marrow was positive for AML, and she was treated on the same line of leukemia protocol. So acute leukemia sometimes can present with an isolated orbital mass, and if you're suspecting it, all we have to do is to get a peripheral smear done. We really don't have to go ahead with an invasive procedure like a biopsy. So this is quite obvious, bilateral rapidly progressing proptosis in a child with a lot of hemorrhages, and the rot spot on the fundus. We really don't have to do anything else other than doing a peripheral smear, which will give us a diagnosis in most of the time. So no intervention in the orbit, just do a peripheral smear. If you find the diagnosis, the patient goes immediately to a pediatric hemato-oncologist for further management. So another girl, I'll finish with this. She was again a young girl presented with a sino-orbital mass with a displacement of the eyeball, proptosis. So in a sino-orbital mass, our first differential diagnosis usually remains a fungal granuloma, sino-orbital fungal granuloma, which is quite prevalent in our population. But in a young girl who is not immunocompromised, otherwise healthy, it's unusual to find a sino-orbital fungal granuloma. Lymphoma is again possible, but again the age group is not really fitting. Yeah. So since it was a mass, we decided to go ahead with a biopsy. We did a biopsy. It was very non-specific, the biopsy, non-specific inflammation, no specific What was unusual, I just did an incision biopsy, took out a small bit from the orbit, but post of 1 week, this was the picture, which was puzzling. Like, we didn't take out the tumor, we didn't do anything, just took a biopsy. 1 week, it has almost disappeared, the proptosis is gone. So then we started thinking, are we dealing with something else? Right? Because we know that when the patient undergoes GA, though we have not given the patient steroid in the post-op period, because somewhere in the back of the mind it was there, we might be dealing with a leukemia. But we know that during the general anesthesia, the patient do get hydrocortisone or dexamethasone or some steroids. So just one shot, it just melted away. And we repeated the imaging, this is how it was. Little bit residual in the sinus, but the orbit is almost clean. Right? But since we did not get a definitive diagnosis, we in fact, her peripheral smear was negative, her initial bone marrow was negative. We repeated the biopsy now, this time from the endoscopic route, because there was more mass in the sinus now. And this time we got the diagnosis. Right? So then over a period of time, in fact, when you repeated the peripheral smear, this time the smear turned out to be positive. We could see the OR rods, we could see the the blast cells. So this is a child who was on the blast crisis, and possibly, I just put this case just to highlight the fact that sometimes they can be so steroid respondent. If we just leave the patient here, we might think that the disease is cured. So I will stop here, and if there are any queries, otherwise we will now move on to the intraocular tumors, the atypical presentation by Dr. Anirban Bhaduri.